Good evening, everyone. Welcome to our 15th session. Today we have Dr. Nandini Vallath amongst us. She's a palliative care consultant at BARC Hospital in Mumbai.
Hello,
She's
Tripti. Hello, Nandini.
also
Hello,
honorary
sir.
consultant in palliative care division at the KEM Hospital in Mumbai. She is on the expert review board of clinical guidelines in palliative care, and she's also the editor and author of Oxford Handbook of Palliative Care. We also have Miss Tripti Tandon amongst us. She is a practicing lawyer based in New Delhi, and she's associated with the Lawyers Collective, which is one of the oldest human rights law organizations in India. In over her 20 years of work, she has been associated with litigation advocacy and community engagement, especially in the area of drug policy. And she was involved in crafting health-oriented amendments to the NDPS Act, which were adopted by the Parliament in 2014. She also serves as a resource person at the National Judicial Academy for the refresher course for NDPS courts. And she has authored several publications on drug policy in India, including position papers for the International Drug Policy Consortium. So we have two experts amongst us who will enlighten us on our topic, which is opioid availability. So welcome Dr. Nandini and welcome Ms. Tripti, and over to you.
Thank you. Sir, which order would you prefer? Regulations first or the medical perspectives first?
Sorry, I have no particular choice. Nandini, please proceed the way you planned it. You know that the group, everyone here has undergone a course in the past, some course on palliative care, and almost invariably, maybe decades back, everybody has had one session on opioid access. Many of them would have heard about it prior to the NDPS amendment. And so I think it will be a balance between basics and more advanced.
Okay, sir. So, Tripti, I could begin an overview perspective, and you could, jump in where the regulatory aspects come. Let's see how it goes. Okay. Welcome to this session, and thank you for inviting me over for this particular session, and really glad to see 40 of you joining in at 7 p.m. on Saturday evening. So I'm going to share my screen, and today's talk will be on the opioid availability, and I will be covering the doctor's medical perspectives, and Tripti will be covering the regulatory perspectives. So as the the presentations are going on, if there are questions, please interrupt and ask them. Or you can keep it pending for the session to the time after we finish our presentations. So we have this NDPS Act and the narcotic and psychotropic substances. They are essential medicines. They are required for emergency care. It is required for moderate to severe pain and for management of intractable symptoms and for agonist therapy. And that is how it has found its place in the essential list of WHO and our national list and several state lists. So these are essential. Now, because pain relief is essential and treatment outcomes as well as treatment experience can change if there is not adequate pain relief, because it can affect the therapeutic relationship. Patients may stop coming for the, even curative patients may stop adhering to the treatment. And it has been shown to worsen treatment outcomes and lower survival because many of them just, stop coming. Even the treatment experience is with high distress and pain affects daily activities. And 1/3 of them describe the pain as intolerable, even during curative treatment. So we need to control the pain for improving the anti-neoplastic treatment in cancer, and unnecessary utilization of healthcare because of inadequate control, and we want to improve survival. The treatment experience will also be improved and the quality of life will improve. So giving that as a relevance for why we want the opioid availability, let us look at this particular map of the world, which is very disproportionate. Even if you compare it with the geographical map, you can see that the entire Asia is sort of completely compressed, and Canada, USA, Australia, as well as some of the European countries are fattened out. This is actually the distributed morphine equivalent, an estimated percentage of need that is met for the health conditions associated with serious health-related suffering. Okay, so a very high percentage of serious health-related suffering is due to inadequately treated pain. So when you can see that the amount of availability of morphine equivalent in these countries is very different from what we have in India, which is 4%. Okay, so just to we understand it is so poorly available, and this is not a very old map. It is in 2015. And so I will be presenting this poor lack of availability of opioids under these headings from the doctors or the medical professionals' point of view. So how does the attitude affect it, and how our knowledge can affect the availability, and how our skills can affect the availability. So beginning with the attitude, I just used the word called serious health-related suffering, which you might have heard now that you're doing the refresher course, because it was recently coined by a Lancet commission. And they define suffering as health-related when it is associated with illness and injury. And they call it as serious when it cannot be relieved without medical intervention, and also when it compromises the activities of daily living. So they coined this new term, and they advocated palliative care as one of the ways in which we can alleviate this suffering. And the suffering is pain is a very important cause for serious health-related suffering, along with fatigue, anxiety, and low mood. This has come from this particular report, which was published in 2018. And so going ahead, I want to present to you two studies done by the same research group. One was done between 1967 and 2007, and the other was done in 2016. So you see there is a lot of gap, and you can see that it's the same main first author who has done the study regarding the prevalence of pain in patients with cancer, review of 40 years, and then update with the same systematic review. And it will be important to notice that whatever we found as the prevalence of pain during different stages of treatment in cancer in 2007 is not very different from what we found in 2016. Percentages almost remain the same, despite so much of research and advocacy and availability. The study had not found great difference in the actual presence of pain in these patients. So the relief of it looked like, I have taken a completely different quote. This is not part of the article. The relief of suffering, it would appear, is considered as one of the primary ends of medicine by patients and lay persons, but it is not so by the medical professionals, which is represented by this lack of change over 50 years of development of medical science. And another important aspect is the quality of death ranking, where we are very low, and one of the parameters was access to opioids, and we are one of the worst countries to die in. So unresolved pain is the elephant in the room, whereas many other things are discussed and the pain is not recognized. And so what I want to emphasize with all this is the attitudinal aspects that medical or clinical professionals can bring into, because finally opioid availability, when we talk, who are we talking about? We are talking about availability and accessibility of a patient who needs opioid analgesics for their moderate to severe pain. For them to reach it, somebody has to prescribe and they have to get it from somewhere. So if the person who does not recognize the suffering. The doctor does not recognize the suffering. It does not recognize the pain. And, the patient has very low chance of being prescribed the right drugs. And another issue with pain, especially long-standing pain, is that initially there is a lot of deep concern when someone talks about pain. And then they start treating it with whatever we know. And then when it doesn't respond the way we think it should, then slowly complacency sets in. And then later on, it becomes like, avoidance of that patient because the patient says no relief, no relief. And further, it becomes hostility. And then we may even bring in different reasons. This patient is, addicted, or patient is psychologically abnormal. So we may try to justify and try to keep away from that patient. That initial concern gives way to many other things. These are few issues related to the attitude. Another attitudinal issues towards the opioid medications, difficulty in accepting them as real medicines because of the history. Several centuries have gone by where the world has known opioids. Initially, they knew it for, getting as a trade crop where it was grown only for creating patients who, people who cannot do without it. Then it became a drug of addiction. Then the next century, 19th to 20th century, looked at eradicating it. So all the language was about illicit use and war against drug and, war against brown sugar, etc. It's only towards the end of 20th and the early 21st century that it is being, seen as medicine. So the attitudes of medical professionals towards the medicine also, opioid as a medicine also is an important contributor to the lack of availability for patients who need it. So there were regulatory issues in prescriptions, and you can see that India is not featured in this, but you can see that many countries had various issues. Even they could only prescribe for a few days. They could they had to be eligible physicians. There were restrictions on the physicians. So all these different levels of issues were there. All this indicated the policy level attitudes which affected the opioid availability to the patient. So any error, there was a fear of punishment. Tripti will elaborate much more on this, and both for the medical professionals as well as for the pharmacists and chemists, there was a fear of being punished, and the punishments were pretty severe. Now, even after our amendments, punishments are still severe, and Tripti will give you a better idea about it. So attitudes, have all been created because of this history towards pain, towards suffering, towards opioids as medicines, and also the restrictions which have, sort of bound the doctors out of fear. They don't want to get into any hassle. Okay, so now let us move on to, we have sort of summarized the attitudinal issues. I'm sure I have missed several more, but this was just to give you that there is a huge factor there. Knowledge-wise, there are many things which come in the way of making opioids accessible and available to the patients. One is the, see, I'm giving a lot of cancer examples because that is the most common type of patients we see. And so you can see many people think that it's only towards the advanced stage of the disease that moderate to severe pain appears. But this particular study, which I mentioned earlier, published in 2016, very clearly gives the percentage of, this is not just presence of pain, presence of moderate to severe pain. Even in stage 1, nearly quarter patients have it. And of course, in the advanced and stages, it's 70%. And if you average it out for all stages, almost 50%, 50.70% have pain. Now, this is an important study. You might have heard about it in some other session regarding pain or medicine or something. This was a study done in 4 regional cancer centers, and they studied 1,600 patients. And the important point that I want to bring to your notice, because we are talking about how doctors' knowledge comes in the way of opioid availability. So you can see here, patients with mild pain, the pain management was reasonably, appropriate and adequate. There was not much of an issue. But when the patient had moderate to severe pain, you can see the huge difference of, how many patients got a proper, adequate prescription shown by green, and what high percentage had inadequate prescription, despite them having moderate to severe pain. So where does this fit in? Probably part of it fits into attitude, but a lot of it fits into even knowledge-wise. So just if you want to prescribe opioids, many of us have knowledge about intravenous injectable opioids and, morphine, and many of us have used it in emergency or in anesthesia or surgery. but there are many other skills that are many other knowledge aspects that we require. One is recognizing the right pain, which is opioid sensitive or not. I'm not going into the details of it because you must have had a important lecture on managing pain and how to recognize which are the ones which will respond to opioid. So this is a very crucial knowledge which doesn't come from undergraduate training program. This has to be specifically sought out as of now. Some efforts have gone in, but still the faculty in medical colleges are not really oriented enough to give this particular aspect of practice to their students. So this is an important extra skill that the doctor needs to seek. So besides the ladder, now the story is slightly changing. It is more like, the different groups of drugs and choosing the right drugs at the right time. So the latest guidelines of WHO for cancer pain, it shows it's not just sticking to the ladder. It has many other components fitted into it. So we need to update our knowledge on managing pain based on the research evidence. Second thing is the dilemma. Relieving pain is of course ethical, and it causes, it is important to remove the suffering, and it also improves treatment adherence, etc. But what about non-medical use? So some knowledge is also required to overcome this dilemma of doctors who have the good intention of prescribing, but they're always worried, they're scared. Not just punishment I talked to you about, but other than that, they're actually worried that am I harming this patient more? So inadequate fragments, because we haven't, grown with using it. We are still using beta blockers. We are using many drugs with major side effects and issues, but we have grown with it. We have seen our seniors use it. We see it, during our training period. Then we ourselves use it under supervision. So we become very comfortable prescribing drugs with major side effects. But when it comes to opioids, we haven't seen too many seniors using it. And so we become a little nervous about every little news that is against it. And then we get into a dilemma. So opioid-related deaths and the crisis in USA also create a lot of fear in many countries because, they don't want to reach there. So this is an important second knowledge skill that we need to have, evaluating the patient. So not only evaluating the pain, but evaluating the patient in whom the opioid therapy is being considered. This is another important knowledge that we need to acquire. Then, that is when I'm talking about evaluating the patient, it's not only about, regarding addiction potential, but it is also regarding comorbidity status. Then, is there a way of following up this patient? What are the other things I need to know before prescribing? There are many other aspects that, will be covered when you're studying the best practices in using opioid. But I don't know if it is covered, but non-medical opioid use is one of the big fears that doctors have. So this is an important knowledge, a lack of knowledge which prevents opioid availability for patients. So the knowledge for there are certain behaviors, like patients keep asking for, they come even when there is no appointment, unscheduled appointments. They may be hoarding. They'll go to one doctor, then they'll go to another doctor. So they keep hoarding these medicines. And there is discrepancy in the pill counts. So these doctor shopping, these are considered as non-medical opioid use behaviors. Again, we need to have this knowledge that it is not just the drug that causes this particular behavior. It's a confluence of the property of the drug as well as individual related factors. Haven't we heard of people being addicted to, nail polish? Or, there are, we all of us have access to cigarettes and alcohol. Some of us are, desperately addicted to it. Some of us are not. So there are two things involved, the property of the drug and the individual related factors. So we need to learn a little more about this. Again, that is a totally different topic. But when I'm talking about the knowledge gaps, which are causing opioid availability issues, we need to understand that non-medical use and how to handle that is another important gap. Even in palliative care training programs, a lot of emphasis is given on teaching people about morphine and how to use it and side effects and everything, but not much attention is given on detecting a patient who may have non-medical use issues. So then we become confident that, how to use it on each patient. So just to give a brief idea, a young male has a high risk and the older female has a lower risk. Addiction at home in the family is a high risk. Depression, psychological issues are a high risk. And patient who is already having history of drug abuse or who is unemployed has also got a high risk and low socioeconomic factors. So when we are taking history of a patient, besides the detailed history about the disease, the pain, and the other comorbidity and the optimization, etc., we also need to check for addiction potential. So this is another knowledge that is an important aspect of being able to prescribe confidently and not be in dilemma. There are even tools, or these are all links. You can just put in certain data and it will tell you what are the percentage, what is the possibility of opioid risk in a cancer patient. So there are certain things that you need to fill in. This is very easy. In few seconds you get an idea, but there are other tools like cage aid tools are there, opioid risk tools are there. And I think it's an important topic that all training centers which teach opioids should also be training. So we have evaluated the patient. We have decided it is opioid sensitive. We have evaluated the patient and decided that opioid therapy can be considered. Now we have to prescribe it correctly and ensure that the patient is adequately monitored. So these are also important knowledge and skills that we bring in. So using other drugs along with morphine to reduce the total dose, like a step 1 drug, maintaining the prescription in the right format, with all name, address, according to the regulations. Why this is important, why I'm talking about prescription in detail is because suppose you have prescribed to a patient medicines, opioid medications, and if this patient has to say travel from Bangalore to Bombay, anywhere in the transit, if they are found with a, suppose they're going to stay in their daughter's house for their 6 months. For 6 months, if they carry, they carry a prescription, even for 1 month, if they carry the medicines, they will want to know whether this is a licit amount that they're carrying. So they need to have a prescription. So we need to give appropriate prescription. Otherwise, we are getting our patients into trouble. Again, opioid availability questions come up. And so even the next refill, we need to work out. So there are some specific places where it does give directories if the patient is not from your place. So just by prescribing once, opioid availability is not ensured. It's an ethical obligation that when we are prescribing a patient, we need to assure uninterrupted supply. So maintaining our own supply by applying for the next refill to our stock, adequately well in time. And second thing is, if the patient is moving, connecting them to another unit which has opioid medication. So all these are, responsibilities that we carry once we start prescribing the medications. So there is a way of couriering it according to the NDPS Act, and maybe Tripti will touch upon it. There is a legitimate way of sending opioid medications to a patient who does not have a palliative care center around them. What are the other skills that are required? So all these are skills required for safe and rational use of opioids, and we have a obligation to prevent misuse and diversion. And we have already touched upon the aspect of detecting addiction potential in our patient population. So skillful selection of patients, skillful prescription, and skillful follow-up. We have touched upon these things. And so all these go into making this balanced practice when we are talking at individual doctor level. So this practice of balancing availability along with preventing against diversion abuse is the beginning of medical and scientific use in the world. So this happened in 1961, and India, including many other UN countries which are under UN, are signatories to this. So we are actually obliged to ensure there is availability and at the same time prevent against diversion and abuse. The main issue in our act before the amendment was they had only looked at preventing misuse and diversion and abuse, but they had not made any provision for actual availability. And that is what Dr. Tripti and many others worked on and amended upon. So they have changed this law, which was extremely complicated to get through, and it became much easier for the licensing procedure for the institutions to stock the drugs. And now they have created a group of essential narcotic drugs. And what are the differences in the rules which pertain to these drugs? Tripti will elaborate on. So now it is much more balanced, and there is a possibility at least that we can prescribe and the patient can access. And now there is a explosion of palliative care centers and opioid stocking in different parts of India. So it's getting lesser and lesser, it's getting less difficult for patients to access another unit where suppose they move. And we have to, so another, aspect of our awareness is how to stock when we have it. So I had looked at the survey that we did with all of you, and many of you, know where it is taught. Some of you don't know. So it's suppose you are the person in charge of this particular medicine, you should be aware of whether the rules are being followed. The double lock system means this is already an open almara, and inside it there is another locker. So you can see that morphine drug is stored inside the locker in a locked almara. That is called double lock system. And the other thing is maintaining the register. So all those RMIs who have said that, they are already recognized RMI, there are 16 of them which answered the survey, and they said that they all follow the NDPS rules. So that's very nice to know. But it is, this is something to be done on everyday basis. And a large percentage of you said you don't stock, or you find it difficult to follow the rules, etc. Maybe, second part of this class will give you more idea of this. And, diversion from our level. We are not concerned with all this. Today, we are talking at the physician and, clinic level. So the level 5, there can still be diversion and misuse if we are not keeping, adequate pill count. We are not adequately assessing the patient for addiction potential. And we don't restrict the prescription to not more than 2 doctors from the unit. So there are certain things we need to do. So this will be an important lecture. If you're learning to prescribe morphine, just like how you will not take the pen out without prescribing a stimulant laxative, at a bigger level, we also say that if you're going to assess the patient for opioid prescription, you should also assess for any possibility of non-medical opioid use. So these are called the universal precautions so of course, we mentioned the assessing of pain, patients, discuss the medications. An important aspect is set expectation and also elicit pain goals. So sometimes when we give opioids, we need to know that some patients will prefer to have some pain remaining and rather, avoid a severe constipation as a side effect. And then screen for NMOU behavior by pill counts, pain diary, periodical review, etc. And monitor outcomes in terms of function. We are not aiming at 0 out of 10 analgesia. We are aiming at improving activity. Initially, we of course try to improve the sleep. Then the patient should be able to sit up. Then they should be able to walk. Then they should be able to do something useful which they enjoy doing. So the important aspect is the outcome of pain relief should not be pain relief alone for the sake of pain relief. It should be that patient is able to do something which they were not able to do because of the pain. And of course, consider some other inputs like physiotherapy or intervention so that the overall pain is reduced. So this is all a skillful prescription. Why we are talking about skillful prescription in opioid availability class is because when we misuse it, when we overuse it, then the patient gets more complications and then the name of the drug gets spoiled. So just like there is a skill in many other aspects of our practice, we need to also consider opioid therapy as an important training for doing it in a complete manner. And of course, diligent documentation as per the requirement of NDPS regulatory things. This was a study done by Dr. Rajgopal when he was in Calicut. And this is just to show you that they studied home care patients for 2 years. And they found that if there is adequate monitoring, there is adequate recording, and there is, the adequate information given to patients regarding stalking and returning, they did not find an instance of abuse or diversion in the 1723 patients they studied over 2 years. So this is encouraging for those who want to use the drug, even when patient is not under your immediate attention. So these are 2 papers that I wanted to talk to you. That if you want to know more about Indian amendments that Tripti will be elaborating on, you can look at this paper. And if you want to know overall in the Southeastern Asia, this also gives a reasonably good background of many countries in Southeast Asia. So to prescribe or not to prescribe opioids, to help the patient, I just want to touch upon why there was an opioid crisis and how it is totally a different world compared to our world, because we need to really understand, because these are discouraging aspects which can affect our attitudes and our prescription. So very often doctors don't prescribe because of fear of adverse effects, fear of overdose, and fear of addiction. And you can see that, the kind of numbers here, United States, Germany, Canada, Austria, Belgium, the developed countries, 35,000 to 15,000 plus. This is the average consumption of narcotic drugs. And you can see this part of the world, Sri Lanka, India. So these are all very low ranking, which are, 96, level of consumption 96, 37 in India. So this is all studied in 2016-18, much after the amendment is done also. So you can see there is a hugely different amount of consumption. And one more thing we need to remember is that when the opioid crisis happened in the US, the primary care physicians were expected to meet, the pain benchmarks set for all, and they had to bring the pain down. And they were allowed to prescribe for medical, for any disease, not just for cancer. So it has the highest per capita consumption. You can see where this is and where India is. And so when we compare the two, this was indiscriminate overprescription that caused the crisis, whereas we are at the level of lack of access even for those who actually need it. So more than 96% of cancer patients in India who have actual need for these opioid analgesics still have no access to opioid analgesics. And another thing to, improve your confidence when people talk, these are all studies. Why I'm showing it to you is because you can show studies to say that these things have been studied already, and they have studied the cancer patients over 10 years. This was a US-based study. So they studied from 2006 to 2016, and this was published in 2018. So they studied the deaths from opioid as the primary cause were 10 times less likely to occur in cancer patients versus general population. There were 895 deaths due to opioids in cancer patients in the entire 10-year period, whereas there were 193,500 in non-cancer patients. And those who died in cancer, with cancer, they were much older. That means, they were more sick, and compared to those in non-cancer population, which were, average was 42. Here it was like 57, closer to 60. Again, it indicates like, we talked about the addiction potential is higher in younger and all that. So we have to look at many other factors when we just put a blame on the drug. It is a lot of other factors. So solution, of course, recognize the serious health-related suffering and look at evidence. And, the second evidence which I'm shown here, aberrant behaviors with prescription opioids in a community-based HIV-infected individuals. So here, most of them had already addiction behavior, substance abuse behavior. And they found that even in this high-risk population, severe pain is common and aberrant behaviors are prevalent, but not universal. So it is not like a person who has substance abuse issue should not be given opioids. They have to be monitored more closely and more differently. So that is the message that I would like to give. Know about how to use it in regular patients, with those with comorbidities and those with addiction issues. So basically our attitude, our knowledge and our skills have a lot to contribute to making opioids safely and rationally available to patients. These are some of the references which may be useful to you, and I request you to refer to that. And there I will stop sharing my screen, and I have finished what I wanted to say. Tripti, I think I took half an hour as promised. And if you want to ask questions at this level, you could, because Tripti's talk will be, focusing on the regulatory aspects.
Do we have any questions from any of our participants? You can either speak or if you want, you can write in the chat box as well.
Yeah, hi, Deepak here. I think one thing is that it's important to note that India has, as much as it is currently on the lower end, very non-US type scenario, but it has all the ingredients for a full-blown opioid problem, in the sense that it has notorious irrational prescribing. It has a fairly unregulated pharma system. So I think the one missing component is the actual access. So as palliative care people, we are always pushing for for access, and rightly so, because people with non-cancer illness, I mean, with cancer illness, especially, should definitely get the care, the pain relief they need. But I think it's also important to, be a little tempered with that advocacy, because, we don't want to uh, cause further, because the problem is it's possible, right? I mean, I don't know.
I can't agree with you more. Yes, I agree with you. That is why I specifically mentioned about the training part. When we are training, we are pushing so much about, using opioid, because it has been so badly missing. But we have to balance that, training along with the capacity, the competency to detect when things can go wrong. And what you say is correct. Things are beyond our control, because it's a highly unmonitored system. And, even if when things are, prescribed badly or irrationally, it won't even be noticed. So, yeah, those are system related issues. But at our individual level, I think today's class is all about each of you practicing in palliative care and prescribing. So the whole aim of this session, at least from my perspective, was you all need to at least know what are the different components that go into safe and rational prescriptions, because that is in our hands. Beyond that, what happens, and pharmacists, and at least we can associate with, after Tripti's lecture, you will also be able to understand a little more about what you need to look into when you choose your pharmacist, if it's outside your institution, or how to become an RMI. All those things you can. I have even given links to a site where you can look at the steps of how to become RMI. So what we can do, we should do. The larger system, it's not just palliative care, or it's not just opioid. It is the entire healthcare system where so many other things are happening. So, if we get into that, there is a never-ending dilemma of what to do. Yeah, but I agree with you. The training has to be balanced. That's all we can do from our end. And the practices, the seniors, the consultants who actually prescribe, they need to show this in their hands-on training program, how everything is being looked into, not just the pharmacological aspects of the medicine, but also about the person. What are the things we are looking at in that patient and family background that is very pertinent to our prescription and the follow-up. They have to actually see the pill count. They have to, so they have to actually see a pain diary. They have to see how it is calculated. So every aspect is important, not just, yes, prescribe. You're right. I agree with you.
Thank you. Thank you.
Thank you so much, Dr. Nandini. That was a excellent lecture, and we all got to learn so much. Dr. Rajam has commented in the chat box, what are the options for private sector prescription monitoring?
Prescription monitoring is the same for any sector. You need to ensure that the patient brings back the strip, and we need to do a pill count each time the patient comes. And you also look at unscheduled appointments, and are they going to more than one practitioner for the same prescription. And before all this starts, of course, a good history of which I briefly mentioned. So we need to have quite a good understanding of how to detect non-medical opioid use from these patients whom you are considering for prescription. And if there is no chance of follow-up, do not even prescribe, because you're just getting into trouble. Because even suppose you say that at least for today and this week, patient will have pain relief because he's right here, but then patient has experienced pain relief, and then not to get that medicine when they are no longer able to come to you is even worse. So if the patient cannot be assured of uninterrupted pain relief, start with something, some other combinations, maybe inadequate, at least some level of pain relief. But starting opioid and then saying, sorry, we can't help you is not appropriate. And also starting opioid and not following up, not reviewing, not titrating is also completely unethical practice. Whether, so. And the urine tests are done as an absolute check, but it's costly, and it depends on the private sector and the individual patient. You can make it into a norm if you think that is required, especially if there is a positive history of addiction potential. Otherwise, most people are comfortable. I showed you that the article which was published where they did not do urine analysis. All they did was keep a prescription count at the patient's home as well as in their register and matched it. So that was adequate. Yeah, so I hope Rajam, this is sorted out. I think she has put one more. During pandemic, this was difficult. What about online consults in palliative? It is not allowed. We have the opioids come under the category of medicines which are not allowed by online consults, because we have put in a petition. You remember that when the pandemic started in 2020, I don't know if you're aware of it, but through the IAPC and National Cancer Grid, we had written to the commission which was making all the rules for online consultation, and I don't think it has got a reply till now. So opioid initiation is definitely not allowed, but what, by twisting and turning the documented words in that particular guidelines for online consultation, we may be able to continue an already prescribed patient who's already on opioids. I think Tripti can put more light on it, but this is what we had decided when we looked at the rules of the online consultation when it was published by the body similar to MCI. Yeah. Urine analysis is for checking abnormal levels of opioid if you're suspecting the patient is, overdoing the medicine. And there is psychological, addictions suspected, psychological dependence suspected, then we do urine analysis. It's a routine practice abroad, but in India, it is not done. Palliative care physicians have not been taken to task, but a lot of psychology, I think I leave this to Tripti. Tripti has actually defended a lot of people who got into trouble because of their prescription. Tripti, I give it over to you. Thanks. That last question can be the transition bridge, and then you can take over. Thanks. Thanks a lot for everyone's questions.
Thank you, Nandini, and great to listen to you after such a long time and to reconnect. Yeah,
Same here.
Yeah, after many years. Good evening, everyone. And thank you so much for making time to attend this session today. And after Nandini's detailed session on good practices by doctors, you now have to hear some dry and drab and very scary things about the law. But just pardon me, because from the survey that Nandini had facilitated, it seems that many of you already have the RMI certificate and are fully complying with the NDPS law and rules. So if maybe some of what I'm saying is already known to you and you're already fully compliant, so if just let me know if this is something that you already know, then I will skip through and maybe have more time for questions if you have any specific queries about what can be done in a situation or not. And I request Arun from Palium India to please share screen for me. Yeah, thank you, Arun. Just go to the next slide, please.
So, I just wanted to clarify regarding the RMI. Not many people have responded to that question. So those who have responded are only 16, and they are the ones. So they are, a high percentage is shown there. Out of 16 responses, 93 were, but the number who were supposed to respond are very high. So a very small percentage are RMIs. Just clarifying it. Thanks.
So yeah, so the first question is, if this is opioids and prescription and how to treat patients is primarily a health issue. And it is quite strange that in this health context, we are talking about a law, and that too one of the most draconian laws in the country. Please make no mistakes. The NDPS Act is the most draconian. It is more draconian even than the anti-terror law, which is so much in discussion today. Even the Supreme Court of India has noticed that, saying that the Unlawful Activities Prevention Act, or UAPA, is more lenient than the Narcotic Drugs and Psychotropic Substances Act. So why are we talking about this excessively punitive criminal law in the context of a health condition. And this is thanks to work not that lawyers did, but doctors did, like Dr. Raj Gopal, who noticed that they were failing in their duty to treat patients because of lack of availability of medicines. Next slide, please. And they were able to make a connection between the lack of access to medicines and the law of the land, which is something that mostly doctors do not do. It is for legal researchers and scholars to perhaps make that connection, but it is thanks to all the research that Dr. Raj Gopal and his colleagues put in that we were able to identify and pinpoint the NDPS Act as being responsible for the decline in access to morphine in the country. And this is really his work in the Lancet, which showed that morphine consumption in India fell just after the enactment of the NDPS Act from 1985 to 1997. And you see, I mean, the population, including the population of patients needing access to morphine, would have increased during this 10-year period, but actual use declined considerably by about 97%. Next, please. So what is this NDPS Act? This is the Narcotic Drugs and Psychotropic Substances Act. It is enacted on the basis of international agreements on drug control that India has signed. The law itself has three purposes. One is to prohibit, which is to say absolutely outlaw some things, but at the same time control and regulate. So I just want to make it clear that it is not that the regulatory aspects have only come in after 2014, after we started working on the amendments, but the regulatory aspects were already there since the very beginning. So on paper, India was fully compliant with the skeletal framework of the conventions, which require drugs to be made accessible for medical and scientific purposes, and also to prevent diversion and not allow non-medical use, what Nandini alluded to. So on paper we had this framework, and all the activities, whether it is cultivating, when it comes to plant-based drugs, whether it's manufacturing by pharmaceutical companies or other manufacturers, possession, sale, all activities from seed to sale were under the rubric of prohibition, control, and regulation. And apart from the act, which is the main framework, the nitty-gritty of how things are to be done, especially the regulation part, what levels of control, what needs to be done by someone who's authorized to use these medicines, all of that was laid down in rules. Rules also called delegated legislation, and rules are not made by parliament, rules are made by government. They are not instruments that are kind of legislated upon in parliament. And for NDPS, we have central rules or rules framed by the government of India, which apply across the country, and we have state rules. So each state has its own set of rules on regulating some of the narcotic drugs and psychotropic substances. So this is broadly the framework. Next, please. So what sort of substances are part of this law? And the substances are directly relatable to the three conventions, the three different agreements that India has signed. So narcotic drugs are what are contained in the 1961 convention, and under Indian law, they are further divided into two categories: manufactured drugs and essential narcotic drugs after 2014. So you will come across some of these terms, and some of it may be completely confusing, but just bear in mind narcotics relates to the 1961 convention. Then there is psychotropic substances, which relates to the 1971 convention, and then there is a third convention of 1988, which looks at control substances. Now, internationally, the word control substances is used to cover all drugs under which are under international control, including narcotics and psychotropic substances. But under Indian law, this is a very specific term, and control substances mean precursors. So chemicals that are used to manufacture narcotics and psychotropic substances, particularly heroin and methamphetamine and other recreational drugs. So when we say control substance, we do not in the Indian context mean the general term of anything under legal control, but a very distinct category. And importantly, the government has the power to either add substances to this list of what is controlled, or to remove something which is already under control, to say, okay, now we don't need to control it, we can have it outside the NDPS Act, or even in certain categories have exemptions. So depending on the percentage of the narcotic substance in a particular preparation, the government can say anything below this amount is exempt and anything above this amount is in the act. Now, again, this is done by the government of India. It does not require the government to go to parliament. So what is added, and India has only added things. We are yet to declassify any substance from our schedules. And this is done purely by the central government without really getting parliamentary sanction or approval. Next, please. So again, just a description, very broad description of what are the drugs that we are talking about. So narcotics, the first category really is the three plants: cannabis, poppy, and coca, and all the products that come from these plants, which are considered narcotic drugs. And then there is a category of manufactured drugs, which are really the synthetic version of the ingredients from the plant, but then synthesized chemically, etc., and include morphine, codeine, diphenoxylate, heroin, etc., etc. Then there is psychotropic substances, which is again a whole list of drugs. So things that right now do not have any recognized medical uses, like LSD or methamphetamine or MDMA. Those are also psychotropics, and drugs that have known medical uses are also psychotropic. And controlled substances, as I said, precursors. Two commonly, that you would be familiar as medical practitioners, ephedrine and pseudoephedrine, are controlled substances. And I just want to say that there is a lot of literature available, and there is criticism from legal and health personnel, scholars, to say that really this classification between what is narcotic and what is psychotropic is quite artificial. It really doesn't have a very concrete scientific basis, because as people point out, that while cannabis is considered narcotic, its constituents like THC are considered psychotropic. So when you find cannabis, you will find some of it. When you start declassifying its components, you will find THC there. So then, what does it become? Is it treated as a narcotic, or is it treated as a psychotropic? And these questions do come up, especially even in criminal cases where there is forensic examination, and a lot depends on the identity of the substance. But also from a health perspective, there has been criticism of this international classification. Next, please. So, this is a question that I would like to kind of flag for all of you, and make it very clear that just because a substance is under the NDPS Act doesn't mean that by itself it is legal or illegal. And you will have people saying, oh, narcotics are illegal drugs. oh, psychotropics, these are all illegal drugs. So there is no such thing as legal drug or illegal drug. What the legality really depends on, what is it used for? The purpose is what matters. So if the purpose is medical or scientific, and for some substances even industrial or horticultural, it is legitimate. At least the first threshold of the purpose being legal is established. But simply purpose being legal is not enough. The second thing is that the manner in which that drug is procured and used must also be in accordance with what is given in the law. So this is where, again, the act and the rules, and if there are any permits, licenses, authorizations, etc., all of that come into being. So really it is not a question of whether the drug is so a lot of people will say, well, cannabis is illegal. But actually, if you see, our legislation and rules allow for medical use of cannabis also. There are, it's possible for practitioners, medical practitioners, to prescribe cannabis, medicinal cannabis, tinctures, etc., even ganja in some states, to patients. So while, in popular parlance, we'll say cannabis has no recognized medical use, or at least allopathic medicine does not recognize its use in India, though in other countries it is. That is not the case. If it is used by a patient, if it is prescribed by a doctor, and it is procured, etc., in the manner that the law allows for it, there is nothing wrong with it. So this brings us to this question of, what are we talking about? Are we talking about medical drug, or are we talking about medical use? So medical drug really on its own. So if a substance is part of the pharmacopoeia, of course, then it is recognized for in medical science, used for its therapy, etc. But that alone is not sufficient. So unless you kind of also abide by the regulatory aspects, simply having a medical drug with a medical practitioner, which is recognized in pharmacopoeia, etc., is not sufficient. And there are two recent judgments of the Supreme Court, where the court has made it very clear that even if the drugs are all medically recognized, they are part of the drugs and cosmetics rules, they're under any of the schedules, that means that their use is known, they're recognized and regulated under the medicinal drug law. So long as they are in the NDPS, you have to comply with every clause and provision of the NDPS Act and the rules. Even the slightest breach will make you liable for prosecution under the Narcotics Act. So this is very, very important, because whatever the law prescribes has to be followed. Even the slightest breach under the NDPS would mean that any protection that you would otherwise enjoy as doctors, as people skilled in the field of medicine, any of your professional academic background, even your bona fide use may not be enough to safeguard you from prosecution if there are any breaches, including inadvertent breaches. So to kind of respond to the comment that I think Deepak made earlier, saying that yes, we need to be careful, and we need to have regulations in place so that the drugs are not misused and maybe patients do not get addicted. Yes, we fully understand the sentiment and the need for this, but please appreciate that when we say regulate, the only option our government gives is NDPS regulation, and NDPS regulation means even the slightest of mistakes means you're under this draconian law. So while you would like to, so all the good practices that Nandini spoke about, examining your patient, looking at their medical history, looking at urine analysis. These are all very good clinical practices. But if we were to make this part of the NDPS system, the universe under the NDPS Act, imagine the consequences. That one patient you don't do urine analysis, you are liable under this law. The most draconian consequences possible under the current framework. So we have to be very, very careful. And unfortunately, in our country, we don't really know what regulation is. All when we say regulate and control, we say do this, otherwise you're in to punishment. And I don't think that is the best way of inculcating good practices. I don't think it's the best way of getting people to act in responsible and responsibly and ethically. There are better mechanisms of ensuring compliance, but our system really doesn't cater to that. I think there are some questions in the chat box. I'm really should I address this now, or can I come back to this later?
However you feel comfortable.
I would just prefer to come back to it later, unless, of course, someone can just answer it as Dr. Raj has. I think that's fine. Then I needn't. So next, please. So what were the problems with our law? Why was there a need to modify it in 2014? Like I said, on paper, our law does allow medical and scientific use, and our regulatory system also had. It was not that doctors could not access or patients couldn't access the medicines. Of course, the framework was there, but it was a complex framework. And the complexity was primarily because the regulations were very, very different. The regulations for morphine in particular, which is a manufactured drugs, part of it, like actually producing those drugs, that was regulated by the central government, but its actual distribution through licensed pharmacists, through to hospitals, through pharmacies, to patients, to cancer care centers, all of that was really regulated by state under state rules, and each state had its own set of rules. Next, please. So state rules meant that, so when you're a hospital and you need to stock morphine, that simple act of stocking morphine will mean that you are engaging in many activities under the law. So you are buying, placing an order for these drugs to be sent to you, so you're purchasing. The drugs are coming to you, so you are involved in transport, you are a recipient of the transport. They reach your office or your hospital, that means you are in possession. You are further selling it to patients or giving them at a subsidized rate, that means you are dispensing, you are involved in sale. So one simple act of stocking medicines itself entails multiple activities, and under the state rules, each of these activities had to have a separate license. You had to have licenses for all of these activities, and sometimes the license giving authority was not the same, so you needed different licenses from different authorities, and all of those had to be valid at the same time. Also, another big problem was that we had, every state has its own rules. So if you were to say the manufacturer is in one state and the hospital is in another state, you needed permission to import and export. This is all within the country, but this was still necessary. So the manufacturer had to have multiple licenses in their state, and the recipient hospital had to have multiple licenses in this state. And of course, there were some states that had not even bothered to make rules because they didn't think that medical access was important. Next, please. So this is Nandini's slide. Really, this was, what we were in. Next, please. And this is Dr. Raj Gopal's article, which really described the problems involved with access. Next, please. So what was done? What were the palliative care practitioners doing when they recognized that this is the hurdle? They advocated with the concerned authorities, and that advocacy resulted in the framing of what was called a simplified model rules. This was like an informal document which was submitted to the Department of Revenue of the Indian government, which looks at the NDPS Act, which is responsible for administration of the NDPS Act. And the department, to its credit, did circulate these model rules to the states and said, we would like that you adopt it, but it was still up to the states, because the rules were really the state subject. It was up to them whether to adopt it or not to adopt it, and most adopted it either partially or didn't adopt it, or it was still quite messy. Some doctors and physicians also approached the court, so there were petitions filed. But that again, took a very long time, and there weren't too many concrete results. So finally, this option of reforming the law itself rather than the rules, really reforming the law, was explored in 2012. And this was when the government had itself introduced an NDPS amendment bill in Parliament. But that bill had nothing to do with medical access. The government didn't even bother to look at the issue of medical access. And it was only our collective advocacy as doctors, as patients. Next slide, please. That led to the changes. So what were the principles? I think Nandini briefly alluded to this in her presentation. What principles did we really follow in working on the legal reform? One was, as she pointed out, that the law is modeled on international agreements, and international agreements recognize that availability of opioids is indispensable. So there is no getting away. If India claims that it is a signatory and is abiding by international conventions, you can't just abide by the punitive aspects of it. Even the availability and medical use part is your obligation. The principle of balance that she touched upon. And we pointed out that the NDPS Act does allow, but because it has these very onerous provisions in the rules, it frustrates. So as a result, people don't get it. It's not like the law didn't allow it. And of course, this that, Dr. Raj and others pointed out, that most of India is the leading manufacturer of morphine the world over. It was at some point. And most of it goes abroad. So American patients get it, but our own patients back home are denied this. And the fact that we have shown, states like Kerala had shown, the slide again that Nandini mentioned, that if there is proper monitoring regulation, then you can prevent diversion, and if not fully eliminate it. Next, please. So these were some of the activities we were involved in, and I think the most important was the advocacy with the MPs. Next slide, please. And here are just some snippets of all the different letters and editorials that perhaps, some of you on the call also wrote or signed up, and saying we need access. And I think really the turning point was when patients or their family members started writing to government officers and members of parliament saying, we want, we cannot bear the pain. And, on a lighter note, I just wanted to share that we had worked on a template. Nandini will remember, we worked on a basic template for this letter. And I think one of the sentences had some grammatical error towards the end, and that same letter went in like hundreds, in several hundreds. And then later this officer who we worked with just joked and said, at least you could have corrected the English. Even the grammatical errors were common in all the letters that they received back in the department. So yes, but this is really, I think it's a very, very powerful example of community mobilization, where people directly affected are taking charge and are really, alerting the authorities to their plight and saying, you must act. Next, please. And this was then successful when in 2014, just before the parliament dissolved for fresh elections, the amendments were cleared, and they came into force on 1st May 2014. Next, please. I'll be quick, I'm mindful of time. And the Indian delegation at the Commission on Narcotic Drugs in Vienna spoke in glowing terms about the law that they had passed, and that they were drafted with the active participation of civil society and the palliative care community. So really all of our efforts were acknowledged internationally by the government of India. Next, please. So what were the main changes? I think the first notable change is that one section which lists out all the purposes of the NDPS Act, which were initially all punitive, now includes promoting medical and scientific use also as one of the objectives of the law. So this is really broadening the purpose. There was a new category of essential narcotic drugs, which was created, which the central government could notify. Again, no need to go to parliament for this, government can do it. And then the rule-making power for essential narcotic drugs was transferred from the states to the central government. So these were the three key changes. Next, please. I can just skip this. Next, please. Yeah, these are this Nandini told you about. Next, please. So based on the changes in the law, the government introduced the central rules, so uniform rules applying throughout the country from 5th May 2015 in relation to essential narcotic drugs. These rules have been now in force for what, over 6 years, more than 6 years. But there are some problematic aspects. They're in dire need of amendment, and we are working on that. Unfortunately, government is not paying heed. Next, please. Just can you do enter? I don't know why this side is blank. The right side. Yeah. So the changes really are, I'm sure you're all familiar, no need for multiple licenses, only one. If you are a medical institution wanting to stock and dispense, all you need is a single RMI certificate. There is one agency now which you need to approach, which is the State Drug Controller, not any other authority. The certificate is valid for 3 years and it can be renewed, and there are no different procedures. This is standard throughout the country. Next, please. Now, this is some level of detail about what is in the rules. I will just come to the more important ones. Next, please. So who can apply for RMI? I think this is important, that it is not just a hospital, but even a clinic. And I would understand that the difference between a hospital and a clinic is this clinic is only for outpatient persons, outpatient basis. So even a clinic can be an RMI. You need have to have patients admitted. Also, government established health institutions, or those established by any person or body of persons. So an individual doctor's clinic can also apply for RMI. A charitable hospital set up by a trust can also apply for an RMI. There are no restrictions, no distinction between government, private, who's the owner, what is the board, this, that, are you registered, not registered, no such issues at all. And once you get the RMI certificate, you become a recognized medical institution under the rules. Next, please. This is now important because for the first time, prescription and the model of prescription has come into the rules. Now, I leave it to you to decide whether this is a good thing or a bad thing. I think from the point of view what Nandini said about regulating, it is definitely important. But in the backdrop of what I said, that once anything comes in the NDPS universe, any divergence, whether advertent or inadvertent, even the slightest of breach makes the person liable under the NDPS Act. So any mistake in a prescription, it could just be a slight error. You got the date wrong, you got the address wrong, and somebody hauls you up. This, you're now within the framework of this law. So there is, it's there are two sides to the story, is what I would like to say. Another important definition is that of a registered medical practitioner. So this again, now all of these aspects which were not otherwise part of the law, most of the regulation was for the drug manufacturers and the chemists, etc., who deal in substantial quantities of the substance. Now we have doctors and medical institutions also coming in. Now, we wanted this because we wanted a uniform framework in the rules, but is there a flip side to it? Are there potential risks? I think we will know in times to come. But for a registered medical practitioner, and this is where the issue has really become complex, is that ordinarily this is just somebody who has done their medical course and who is registered with the Medical Council of India, or whatever authority now there is for regulating medical practitioners. But for the purposes of the NDPS rules, you also need to be an practitioner who has undergone training in pain relief and palliative care for prescribing essential narcotic drugs, or in opioid substitution therapy, if this is for the treatment of drug dependence. And the question really is, what is this training? How does the police or how does the regulatory authority assess whether I've undergone training or not? And this is something we have been grappling with, and I'm not sure the Ministry of Health or the Ministry of Finance has sorted this out yet, even after 7 years. So there is that this remains a kind of a gray area, because you may say I've attended this course, so therefore it is training. Now, if somebody is inspecting you, will they agree that this is proper training under the law, or will they say, no, you have to show me some government certificate saying you have undergone this training and things like that? So this is a bit of an issue. Next, please. Yeah, next, please. So under the rules, who can possess? Patient, of course, but only the quantity sold or dispensed at one time. So you will have to see in the prescription, how long are you prescribing? Is it for a month? Is it for a longer duration, and things like that? Because for the patient to be compliant with the law, they need to only possess what is in the prescription, and anything above that will be a problem. The registered medical practitioners, there are two categories. One, you can just possess certain amounts which are given in a table in one of the rules, which is very basic quantities, small minimal quantities, for direct administration to your patients, actual direct administration to your patients. Then there are other categories where doctors who want to stock more, larger amounts, need to get a specific authorization from the state drug controller. And for that, and on the basis of that, they can have a larger quantity stocked. RMIs, of course, once they have the certificate, they can also possess. I'll just skip some of the others. Next, please. Also educational, scientific institutions, ambulances, emergency use, etc. All of this, but you need to have authorization from the state drug controller. Next, please. Who can buy from a manufacturer? A medical practitioner can also directly purchase, an RMI can purchase, and anybody who's authorized by the drug controller can purchase. Next, please. Who can sell? So chemists, of course, chemists have to be licensed for essential narcotic drugs. I'm not sure what the status is, whether they get END licenses or not. And also recognized medical institutions can sell to their registered patients. Next, please. RMI, like I said, you need to apply in a given form. Within 60 days, you should be granted. On what basis does the state drug controller grant you? What do they look for? is not specified in the rules, and I suspect that once again different states follow different criteria. Maybe others can talk about this. The certificate is valid for 3 years. After that, you can renew it. You can be suspended, it can be cancelled. You can also return it. You can also surrender if you don't want to engage in ENDs at all. Government hospitals are deemed to be RMIs. They don't need to undergo any registration, but they need to comply with the regulatory requirements, such as record keeping, filing returns, etc. Next, please. Every RMI has to have a designated medical practitioner as in charge, and it seems the wording of the rule seems that only this doctor can dispense. So I'm not sure if there are other treating physicians who are not designated as medical in charge under the rules, whether they can dispense. There seems to be some confusion. You need to give an estimate of what quantity you will be stocking, and once that is approved, work with that. And if you need to increase, then you need to submit a revised estimate before the end of the period, I think in August of the year. There are records of the stock, patient registration. There are lots of forms and paperwork. I think some of this Nandini talked about. All records have to be preserved for 2 years minimum, and inspection by the state drug controller at any time, and disposal as per the state drug controller's orders. Next. Home care treatment is also allowed to a patient who is registered with the RMI, and then the designated doctor can nominate any qualified personnel to carry the medicine to the patient and give it in their place of home or stay, and bring back the unused drugs in case the patient has passed away. Next, please. There are some other provisions. There is now no special requirement for interstate export or import. There is no such thing. It's all standard. But at the same time, there is a requirement of a consignment note if it's being transported. But if you're a doctor or an RMI, then you don't need the consignment note. That is not required. And this was a question I think somebody had asked some time back, whether can you give, if you are an RMI, can you kind of give it to another institution that needs it? No, you cannot. You have to just keep it to yourself, even if that institution is also recognized as an RMI. No transferring, loaning, sale, etc. to any other institution. If there is a change in your the board, suppose you are a trust, registered trust or a society, and there is a change in the constitution of your board, this is important. You have to within 30 days inform the state drug controller, and after that you get a fresh RMI certificate. And this is something we tend to overlook, because we say, what is the big deal, so long as I'm maintaining all my paperwork and records. It maybe just slips your mind, but sometimes agencies catch you on things like this, that, oh, you didn't inform, so therefore all of this is now against the law. It's a contravention. So this is important. Whoever the designated officer is must within 30 days inform of a change in the constitution of the board. Next, please. Yes, as I said, prescription is now regulated by the rules. These are some requirements. I can just skip this. Next, please. Yeah, this is the implementation status. This is some RTIs we had tried to send and get information. This is slightly dated. It is still March 2020, so maybe things have become better after this, but only 15 states had issued RMI certificates. Importantly, 13 states did not even respond to the RTI request, including states like Kerala, which we are otherwise in awe of for this, but they didn't reply. Several other states didn't reply, especially in the south. I think we didn't get responses, though I think southern states in general do better. So this was a mystery to us as to why they were hesitant in replying. But basically the RTI showed that the status of implementation of the rules was pretty dismal. We came across instances where a small state like Delhi had issued a substantial number of RMI certificates, and a large state like Maharashtra had only issued 4. So you can just imagine the status of patients there. And some states were still issuing under the old rules, which are clearly overridden. So yeah, there were a lot of problems. Next, please. So there are other issues. I think there's something going on in the chat. I'm sorry, I'm not following the chat. But yes, tramadol has been added under the NDPS Act as a psychotropic substance. So when we talk about opioid availability, the law is very different. If it's a manufactured drug, if it's a narcotic like morphine, the END rules will apply. For tramadol, END rules are not applicable because it's a psychotropic substance. So if you are an RMI, you're stocking morphine and you're also stocking tramadol, you need to be clear to follow the tramadol rules separately. They are nothing to do with the END rules. So this kind of multiple regimes for different substances would still apply to you. Also, as I think Nandini alluded to, the NDPS Act is very draconian, and penalty depends on the quantity of drugs. How much is found in your possession, or if it's in someone else's possession and you are ultimately the originator, what is the quantity? Importantly, last year, the Supreme Court in a decision, it's an unfortunate decision, said that the entire quantity will be taken into account, including non-narcotic and neutral materials. This has very serious implications for pharmaceuticals and medical drugs, because it just obliviates the difference between the API, the active ingredient, which perhaps is an opioid, is a narcotic or a psychotropic, and excipients, which are there in most pharmaceutical products. Different pharmaceutical strengths perhaps have no meaning, whether it's 0.2 mg, 0.4 mg, etc. Really now that distinction is lost sight of, because anything with any amount of the narcotic means the whole tablet or the whole syrup becomes, or the whole injectable preparation is counted as a narcotic drug. And single and combination drugs, for instance, tramadol alone and tramadol with paracetamol, no difference really in the eyes of law, because you will take the total weight and then prescribe quantity. So in light of this, what happens to the quantity limits prescribed for doctors and patients under the law? This is a serious question. And next, please.
Sorry to interrupt.
This is the last slide, and I would urge you to read this really, interesting article very recently, which pinpoints a lot of the problems that we have been talking about in the context of the law and pain relief, saying that though we've amended, there are still a whole lot of problems, and tramadol particularly is described. So yeah, I'm just in time. Thank you so much.
Thank you so much. Since we are almost at the end of our session, but we had so many questions in the chat box, and this is probably our last session with the lecture. Can we have some inputs from our faculty, especially Dr. Raj? He has been answering so many questions in the chat box.
Tripti, totally unauthorized, in an unauthorized fashion, I have given answers in the chat box to so many questions because he knew there wouldn't be time. But there are some still pending.
That
Specifically, your input is necessary for this question that has come up. If there is pilferage of pills by others who had somehow get access to the medicines, will the doctor in charge of RMI be held liable?
if there is pilferage, at what level?
Vivek?
I think the question was mine.
At the level of the patient?
Yeah, at the level of the physician, or while stocking, while coming to this thing, because mostly what happens is it's dispensed, physically dispensed, maybe by another doctor or by the pharmacists in that this thing. So uh, would the doctor who signs off the stocking order be liable for anything that happens, like if it's prescribed to a patient, for example, in good faith, and the patient goes and sells it? That's like, I mean, like, so at that level, will the doctor still be held liable is the question.
Tripti, just I'll add to Vivek's question, this comment, and then please answer. My answer is nothing can protect anybody from having a case filed against you. You may not get punished, but that is still a possibility, right, Tripti?
See, what ordinarily happens is that the police will say, at the level of the patient, or somewhere else, if they find somebody with medicines which they're not supposed to have, or for which they can't show a valid prescription, they will ask that person, where did you get this from? They will interrogate, and that person will probably take names and say, I got this from this institution, this doctor so and so gave me, if he knows the name of the doctor, or if he just says so and so hospital or so and so dispensary clinic there, that's where I got it from. That's when the investigating agency will issue a summons. You will be called for questions to ask, to find out what is there. Sometimes if they have suspicion, if they get information that, oh, you are stalking all this, they needn't summon you, they can simply come and search your premises. It's question mark whether, if suppose your premises need to be searched or examined for a case, will it be the state drug controller? Should that office go, or will it be the police or the NCB or whichever enforcement agency? This is it's a question. I assume it'll be the police, although it is important that the state office which has issued you a license should also be involved, so to say that, no, this is an agency who has a valid RMI certificate. But that's not what we have seen in practice, especially with psychiatrists and pharmaceutical companies that have been called in for investigation. And if at that stage you can show your bona fides, you can show your proper paperwork and records and explain how is it that this person got the medicine, you can clear that, I have done things properly, things should hopefully end there. They may ask for copies of your records. They may ask that give us a photocopy of all your certificates or this period, that period, and you will have to give them those. I'm afraid patient confidentiality at some level will have to be breached, but it should hopefully end there. But since it is investigation, one really doesn't know. If it does come to fixing liability, I would imagine that the designated medical practitioner who is made in charge under the rules, the buck stops there. That doctor will be responsible.
Yeah. So if it's another doctor in
Deepak,
Yeah,
I'm sorry.
sorry.
Gauraya, I know that ECHO is rather strict about the timing. Already we have exceeded time by 5 minutes. Suppose, I mean, I leave it to you, Gauraya, but I mean, one possibility is that you could end the meeting and people could stay on and unofficially, or we could get the answers from Tripti and send it to everybody. Gauraya, what shall we do?
So I thought maybe since this is the last session and everyone had so many questions, so that's why I thought maybe we can exceed 5 minutes. But now that we have already done that, if any people would like to stay and unofficially, and that would be probably like face-to-face discussion is like preferable for everyone.
Tripti, do you have some time? Another 10 minutes or so?
Yeah, I'm okay to stay, but
Nandini?
I don't know for other participants.
Can I ask one question, Dr. Ajit?
No, wait a minute. Sorry, Ajit. Deepak asked a question and I interrupted him. Let Deepak just finish one question and then we'll pass it on to the others. There are about a dozen questions pending in the chat box also. So
No, I
first,
mean,
Deepak,
I already asked the question, so if Dr. Ajit can go ahead.
Okay, Ajit.
Can we keep this session on informally and like end it officially
Yes, please.
before we go on to like any other questions and answers?
Okay, Gauraya. So we are just, the session is over. We are just sitting and chatting now. Very good. Tripti, I suppose that is quite legal, isn't it? Informal chat.
Yes, absolutely.
Sorry, Ajit.
Thank you so much. Thank you so much to Ms. Tripti and Dr. Nandini and Dr. Raj and everyone else for attending this session. And so we'll end it officially now and we can go on with the question and answer session.
So, Ria, will you stay on for a few minutes more?
Yes, sir. I'll be here. I'm here.
Okay, thank you.
So can I ask one question?
Ajit, please.
Suppose
over to you.
Suppose the patient who is taking morphine at home dies, and the family fails to return these tablets, and it is no. How will that affect the doctor?
I'll just tell you. So it is the responsibility of the designated medical practitioner of the RMI to keep track of all the unused medicines. So really, one could say that if they don't do it, then it is possible to kind of haul them up for not fulfilling this.
So can I add a little that? So Dr. Ajit, this will again come in our good practices. So when we are prescribing, usually the opioid prescriptions are, little different, where the instructions are informed to the patients and family, and also some, very often printed. So in that, it's very clearly written that, for any reason, if you're not going to use it, so it is on record that we have to make them understand, as well as we need to, give it in writing. Second, that is one part of our job, that we are ensuring that communication. Second part of our job is, as practitioners of palliative care, we will be following up the patient. As Tripti said, it's mandatory whenever we prescribe opioid. It cannot be overemphasized. And once the patient dies, as part of the bereavement process, when we are reaching out to them, this is another responsibility that we have to check on.
Yeah.
So this is not the legal part of it, but it is the best practices in clinical practice. So we need to check out, because we know how many drugs they might have used approximately. So we know that there must be quite an amount pending. Why it is important is not just from the legal perspective or getting caught, but there have been instances where a husband dies, the wife is in denial, and she may use it for committing suicide. You understand?
Yeah.
So it is not, it has got many other aspects to it. So we need to just follow the best practices. Go ahead.
Yeah. Okay.
So Rhea, you want to take on the questions in the chat box?
Sir, I can do that. We have a question from Dr. Hari Mohan. He's asking if it's possible to get a directive from Pallium India or IAPC with set of regulations to be followed by all institutions, which can be shown by concerned RMI, like responsibilities, accounting, checks, auditing, something like that.
Deepa, I don't know, who wants to answer that question. If I understood that question, Hari, properly, a directive will not be, from IAPC or Pallium India, will not be binding, legally binding in any way. Having said that, Dr. Nandini has prepared an excellent document, which is on our website, guidelines for stocking and dispensing opioids. This I have just put up on the chat box. This is there for open access. I would encourage anyone to follow the guidelines given by Nandini in this document. Yes, Deepak, with the quantity returned by the patients are entered in our register as receipt, just the way we would enter a receipt from the manufacturer, and then we use it.
Everyone doesn't do that way. Some of us, we use a separate register so that it, we have a different register when we accept it from manufacturers. Otherwise, the total number, suppose we have accepted just say 100, and of which 30 were given to one patient and they returned 15. So then our stocks change. So that is the reason in our hospital, we keep another register for the returned medicine so that the accounts don't get disturbed. So there are different practices. Basically, accountability. That's the main issue. We need to know where each drug has come from and where each drug is going.
Yeah, thank you, ma'am. That makes sense. Ma'am, I think where my initial question came from was a point of, it was almost from a place of fear almost, because, it's like, if I were to go to another institute where it was not there and set it up, and if I was for example, was the person in whose name the morphine license was taken, and if somebody else in the institute prescribed it in another way, or if it went off from the pharmacy without my knowledge, because the truth is doctors are generally very ignorant about these other things that happen in the hospital in terms of pharmacy and all. You write the prescription and that's the end of it. So my question was more like, should that be a deterrent large enough for me to say, hang on, I don't want an RMI in my name, even though that is not ideal. Because the law is very stringent, right? Obviously.
Would you, from what I understand, sir can add on, Tripti can add on, but when there is one person's name put in the RMI certification process, everyone who's prescribing in that institution, they continue to prescribe, but it is assumed, or the process of an RMI is that all the prescriptions go through this person whose name appears. So the prescriptions don't go directly to the place of, the pharmacy or the chemist, where, it goes through the RMI, the doctor in charge of the RMI. So you have an opportunity to review the prescription And now the question is, very often, suppose it's a very much more highly qualified doctor who has prescribed, and we cannot discuss with them to change or anything, then what happens? So there is a way of doing it, but it is not entirely, some of it is not realistic, because we cannot tell a very senior experienced oncologist that you have to change your prescription. So we need to work around it by education, by getting them to, we don't have to say that you are wrong, but we can take a bunch of oncologists and give them ways of an update on opioid prescription, or bring up this law issue, whatever you need to do to update the information. And they are quick learners, they're continuously learning. So that is another way around, not legal, but these are the practical things. Sir, please add further.
Nandini, if I may just, it's a slightly different perspective that I want to bring in. Look, what you are talking about is whether this doctor may have overprescribed or underprescribed. That really is not the remit of the law. And it shouldn't be, according to me. This is not the prerogative of the police to say whether this doctor, this was overprescribing or not prescribing. What you need to do is, as per the law, that whether there is a prescription, is the prescription with the date, with the registration of the prescribing doctor, whatever requirements have been laid down in the rules, and then accordingly the amount that is being dispensed is as per what is prescribed. That is where your role stopped. As designated medical in charge, it is not for you to sit in judgment over the clinical decisions of your colleagues or even senior doctors. That is not what the law requires you to do. That may be, other like good practices, as Nandini is saying, or clinically, I don't know how you do it, but according to me, this should not become the remit of the law.
So Tripti, you're saying that a person who is sitting as a doctor in charge is not liable for prescription errors, quantity, the actual, practical, the dose and underdosing, overdosing of a colleague. They are not liable. They are only liable when the prescription is inadequate in terms of the legal requirements over the prescription.
Yes.
And even if the patient dies with an overdose due to a prescription by another doctor, the person in charge of the RMI, the doctor in charge, is not responsible.
Yes, they're not responsible. See, overdose deaths is not the subject matter of NDPS. Overdose death may be medical negligence, IPC provisions, etc., or medical negligence law, but not NDPS. NDPS, even if the person has died, so long as the drugs were procured legally as per prescription from RMI, you are not responsible.
And if a pharmacist accidentally dispenses 10 tablets extra or something of that sort, which was which was an error on the side of pharmacy, or the prescription was for 10 but they prescribed 12 or 14 or something. I don't know if, or if somebody decided to shadily set it off in the black, or
Yes, that would be then that person falls foul of the law, because you have to, if you are purchasing from a pharmacy, the pharmacist has to. That's not just under NDPS, even the drugs and cosmetics rules require the pharmacist to supply as per prescription. And in fact, a lot of pharmacists are facing prosecution because of this.
No, but will the doctor be held liable there? That is my...
See, the doctor is not, so long as they can show that yes, this person is my patient. I have the registration of the patient in my patient register, and the name of the patient is there in my prescription. The legal requirements for the prescription are there. There is, the doctor is not responsible under the NDPS Act, because you have complied with this law. You are not responsible. Now, the person dies, NDPS doesn't come in death. Like I'm saying, it's not coming in, because your procuring is lawful. The death is something different.
Thank you. That makes a lot of sense.
There were a lot of questions in the chat box about this the same topic about like which doctor would be responsible for the prescription. So I guess this is an answer to all of our questions. Also, there was a question. What are the
I think the head of the institution may also bear some responsibility, not just the designated doctor, but the overall head will also. Because as I'm going over the forms, you have to mention who is the head of the institution, apart from the name of the designated in charge.
Right, right. So another question is, what are the protocols if we have to send essential narcotics to someone in an area where no RMP is available? So what protocols can we follow in this case?
Sorry, to an area where?
If we have to send, like there's a patient in some remote area and there is no registered medical practitioner available. So what are the protocols to send essential narcotics to this patient?
Smriti, sorry, Tripti and Nandini, can I try to answer that question? And please correct me if I am wrong. The problem is not about sending. As Nandini explained earlier, according to the current Medical Council's regulations for telemedicine, opioids essential narcotic drugs cannot be dispensed, cannot be prescribed over telemedicine. That means one doctor will have to see the patient and prescribe the medicine. This will have to be a registered medical practitioner. So as far as I understand, once a doctor has prescribed it, that can be dispensed by a pharmacy. But here we are in a different position. We are sitting in another city. We don't know this doctor. Unless we know the doctor, unless we know the authenticity, we are unable to do anything. If I have a doctor who is working with us, may not be necessarily on payment, as part of our team, such a doctor sees the patient, then the medicines can be dispatched. Purely if it is a matter of dispatching, medicines can be sent by registered post according to the rules, and by common practice, a courier seems to be acceptable. That's only the matter of sending. But this brings up then another question, Nandini. You did not get a response to your plea to the Medical Council. Would you consider sending a reminder to the National Medical Commission, the new body?
Sir, it is not that I sent it. It is the IAPC along with NCG collaboratively they sent it, and it is a body which decides the rules for all these virtual consultation. And yeah, we could consider a reminder to them. We should discuss it with the president, Dr. Sushma Bhatnagar. And regarding the posting of the courier, yeah, like Tripti, even I have whatever sir said. Suppose the patient has been seen by me, and patient is on a regular levels of the drug dose has not changed. There are no new symptoms, and patient is comfortable. Continuing the opioid therapy by dispatching those doses of a patient who's registered with me, because the patient is staying somewhere else, I guess is all right by the rules, because I have examined the patient when it was initiated and I have not changed the dosage or I have not changed the format or anything. Correct? Is that appropriate?
See, there is a slight problem with the rules about transporting. So as Dr. Raj rightly said, you can send by registered post, but if you examine the rule carefully, it does not allow a doctor or even an RMI to send the parcel. The parcel can only be sent by the manufacturer or the licensed dealer or chemist. So if it is your patient registered in your institution and then goes back to another city or to their village, and from there they say, please send us the ENDs. I think the rules as they stand don't allow you as either the doctor or the RMI to send.
But my pharmacy can send because they are the chemists.
But are they part of the RMI pharmacy, or are they distinctly licensed as a pharmacy under the rules?
Oh, I see.
The question.
Okay.
So there is a slight issue in this. It may be an oversight by the department, but
Tata has been sending. From Tata Memorial, we have been sending medicines to patients.
Pharmacy is anyway licensed, I think. Could be is a large.
And the other thing that sir mentioned, that, you know, someone from the locality whom I have never seen, and, you know, the chemist here has drugs, but the region does not have drugs. And we have never seen this patient. How do the rules stay? Sir said it is not possible. Is there any loophole there where this doctor sends his prescription and identifies this pharmacy as the dispensing pharmacy? So can this pharmacy send it?
See, one could explore the home care treatment thing.
You're talking about another region far away. Yeah.
The home care doesn't say that the patient has to be in your city or state. You know, wherever the patient's home is, you could dispatch.
I see.
Medicine, but the patient has to be registered with your institution.
So that doctor becomes part of your home care team.
Yeah, the doctor, or you can send any other qualified personnel. So that can even be a nurse or somebody else. So that is a loophole we can explore.
Also, I had one question. If suppose I have seen one patient and initially I've started him on morphine, and after that, since the patient is not able to travel, so only his relatives come to me, and I'm not seeing the patient for like 2 months. So should I prescribe the same dose and hand over the morphine tablets to the relative? And also, if the relatives say that the pain is not controlled and I increase the dose or modify the dose, can I hand over the modified dose morphine tablets to the relative?
Legally, there is no problem, but Nandini can answer better in terms of what is medically, what is proper. Legally, if they are your registered patient and they need a refill of the prescription, then there is no, because the rules don't specify that each time you are updating or refilling a prescription, you need to physically examine the patient. There is no such requirement. Thankfully, there is no such requirement in the NDPS rules. But what is proper, I think Nandini knows better.
So was it a legal question?
No, actually, we have been doing this in Tata Hospital. So we had so many patients who just came to us once, and after that, they were not able to travel. So their relatives, sometimes they came from Mumbai itself, or sometimes they traveled right from like UP and Bihar, just to get morphine for the patient. So
yeah. So medically, we have to do due diligence to ensure that, you know, we are doing the right thing. So what I do is video call. When the relative is in my clinic, I ask them to call the patient home and talk to if the patient is not able to talk, somebody will be there. We'll also have a view of the patient. We know the person is alive. We know that the person is in pain. We ask a few questions. So we try to do due diligence and then follow up, you know, instead of just, because there is so much, I'll tell you, whatever the patient says, and when we actually see the patient on video, there are things which they have not even noticed. And, you know, it's so important. So it's not appropriate medically to just go on giving the prescription on the relative's word. We need to have some contact with the patient and review, especially when you're up, you know, going increasing the dose or all that. We need to be doing our own.
yeah, we used to review, but I was just wondering if it is okay to actually hand over, because some institutes, they refuse to do it. But then we used to do it.
No, it has been time, like ever since palliative care has begun, I think this is a practice that is followed. because a patient can, only worsens in physical condition. Patient become more and more bedridden, so it may be inappropriate to expect them to come and visit us for, pain medication. So this is a practice that everyone follows, but we need to do our own assessment, evaluation.